It's my great honor to introduce to you John Fleming, the new HHS Assistant Secretary for Health Technology Reform. That's really why we're here, and we are so grateful to you for coming and agreeing to share your thoughts with us. We think your staff wouldn't exactly confirm it, but we're pretty sure this might be the first, broadly available speech to the public and to the world. This is being live streamed, so please come up and let's get started. We're going to do this like a fireside chat, and just a little bit about his background. I'm very proud to say he is a physician, a family physician, the kind that works directly one-to-one and really cares about the patient relationship. That's very important to me, and I'm so glad that someone that understands medicine as well as you do is in this role. He has served as a representative from Louisiana's 4th Congressional District, 2009 to 2017. He's been an early adopter and supporter of health technology, and he implemented electronic health records in his Minden, Louisiana practice in 1997. That's pretty early. So his public career also includes service in the United States Navy, and he was the 2007 Louisiana Family Practice Physician of the Year. That's not easy to get. Honor among peers. And so, in addition to that, he earned his BS at the University of Mississippi and his MD at the University of Mississippi. So, please welcome John Fleming.
Well,
do you want to talk from there?
I can talk there if you like. Which is better?
Actually,
whatever
that
you
might be
prefer.
better for your
Okay.
initial remarks.
Okay.
Then we can sit down.
Sure.
Okay,
Okay.
perfect.
Thank you. Well, it's great to be with you. I see the signs of Georgetown Law. My son is going to be very, very jealous that I got to speak at Georgetown Law because he's a lawyer and I'm a doctor, and he didn't get to do that. So I'm very, very happy about that. But I bring you greetings today from Secretary Tom Price, a friend and colleague of mine while I served and he served in Congress, and also from our new national coordinator, Dr. Don Rucker, who's been in this space for many years, also the principal deputy national coordinator, Genevieve Morris, and then also Dr. John White. I don't believe John's here today, but he's our deputy national coordinator. And then we also have Devin McGraw, and she is my legal backup in all of this because she knows everything there is to know about privacy. I hope I'm not overselling that, but she's our go-to person on this issue. So let me extend a little bit on my background that Dr. Peel mentioned. I did adopt a medical record system in 1997, and we'll get into why I did that at that time and what the results were. But I was very happy to do that. I'm not an expert in electronic health records or in computers or any of that stuff, but I consider myself an expert in consumption of those things. And there is a lot that you learn by doing that. But let me talk a moment about what we're doing at ONC, the Office of the National Coordinator, that I think is so important. First of all, usability of electronic health records is a huge issue, mainly because how do you get the data from your brain as a physician or a healthcare provider into the machine? And that is a daunting task. And I've actually done my own informal survey over the years to see what people do, and it's really spread pretty even. Some type it all, some click the boxes, some dictate, some use voice recognition. It's a little of everything. And one of the mechanisms that we used was sort of a macro that was tied to the diagnosis. So as soon as you pull the diagnosis up, it populates text, and then you can do minor edits to get to the accuracy of that. But we still don't have a good intuitive way. A study came out last year saying that on average doctors feel that it takes 2 hours of documentation in their electronic health records for every hour that they spend with direct care to patients. Now, we have to fix that. That just is totally unacceptable. And we also have to consider there's a tension between data access to the records, and also privacy. And that's something that you just heard quite a lot about, and we'll talk about more of that. The other big area that we're working on at ONC is interoperability. Now, what's the big deal with interoperability? We go to the internet and you have Apple talking to Microsoft and all of that, right? Well, in the world of healthcare records, it just doesn't work well at all. You've got different platforms, different languages. You've got different types of data. It could be structured data like lab values, or you could have text in the transfer of those things. Even within certain systems, they have difficulty. Even a single proprietary system may actually have considerable difficulty in transferring the data back and forth. So we're working on that. But here's really what we're looking for, is the ability to send data, receive data, find where you need to send it or receive it from, and that gets into patient identification, which is a big problem. For instance, in some larger systems, you may have 10,000 people with the same exact name. And what's the chance that their demographics are going to be very similar, like birthdays? And so even the best of systems, we find that 96% patient ID with a lot of resources put in that is about as good as you can get. So you see the problem. And then also the use of the healthcare information itself. So the third thing that I think is important, and it's emerging over the horizon, is quality measurement. You're going to hear, if you haven't already, about the importance of what we do as healthcare providers, whether it's actually doing any good for our patients, and how do we measure that. And currently under the macro law, which we're in the process of implementing, we're going to be talking a lot about how best to do that without, again, adding even more burdens to what the healthcare provider has to do. So here are the three things that I would leave you with before our discussion here. I would call them endpoints. Endpoint number one is that we need to move to a position where healthcare providers spend as much time in direct care as they did prior to electronic health records. Now that's tough to do, but there are offsets. I can recall having to call the pharmacist to call in a prescription. I can recall having to call the laboratory to get a lab test. Mm-hmm. If we're able to deliver that information instantaneously and intuitively and even in a passive way, where it's right there in front of the healthcare provider without even asking, that's huge savings of time, mm-hmm. which gives us more ability to put more data in and still spend the quality amount of time with the patient. I can't tell you how many times that people have told me they're sick and tired of staring at the back of the neck of their doctor because the doctor's banging on the screen and focused there. And my wife even made the comment the other day. She even wondered whether the doctor was hearing what she had to say. Mm-hmm. So this is a big problem, and we need to fix that. Come up with better ways to put the data in. And also, we've even talked about some futuristic things like sensors. Sensors that may be with the patient, on a watch or something like that, that can put real-time data directly into their healthcare record or indirectly, looking at pulse and blood pressure and blood sugars and all these kind of things. And that also gets into another topic that we won't spend time on, but patient input to data and patient ability to access that mm-hmm. data. So that's number one. Number two, and again, this does not reflect an official position of HHS. This is purely my vision, is I believe that every American should have a single unified electronic health record system that resides in the cloud and is under full control of the patient, of the individual, of the American. Now, is that to say that that person's doctors wouldn't also have at least their versions of that record? Of course they would. But think about it. you go from Dr. A to Dr. B, and how do you get that information that's maybe accumulated over the many years? And how do you get it in a format that's easy for that doctor to use? And so that's a big challenge, but think about the benefits of that each time you go to a provider, the new information is pushed back up into the single unified health record. And of course that creates more challenges when it comes to security and privacy. Now, on the topic of security and privacy, remember that privacy is a matter of policy, and security is a matter of standards. And we work very diligently on standards. And so we may get into that a little bit more. And then finally, machines talking to machines. Being able to transfer data when we want and how we want. And that is, again, a big thing. It's not going to happen overnight. We have many technical challenges why that can't be done. And you may have people tell you, because I get calls all the time at HHS, we figured this out. We have the solution to interoperability. And I go, and so my first reaction is, if you're telling me that, that tells me you don't know anything about interoperability. Because we've got the world's experts in some cases who are tackling that problem. But I am convinced that someday we will solve that problem. We're a bit reluctant at ONC to be prescriptive about that. I mean, we could just come up with a set of protocols and tell everybody they've got to do that. But the possibility of unintended consequences by doing that could be immense. So we're actually going to the experts and asking them, and the vendors, the people the stakeholders, asking them to build a consensus. And we're making a lot of progress, but again, it's one step at a time. One thing I didn't mention to you was that after years of medical practice, in 2008, I ran for Congress, and I was elected. I was the most surprised person of that. And so I've spent the last 8 years serving in the House of Representatives and dealt with a lot of these privacy issues outside of healthcare. Mm-hmm. Remember that the Patriot Act, a lot of concern about Fourth Amendment rights. We found out that there was the NSA was collecting bulk email data, and they did it without authorization, although they claimed that members of Congress knew about it. We did not know about it. And so we came up with some fixes on that, although we found out later that in many cases they were ignored. So this is a huge issue. It goes far beyond healthcare. Privacy is important. I'm not at all convinced that giving up our privacy makes us a safer country. I think just the opposite. And we're going to have to be smarter about it and more technologically based. But privacy and security of data remains an extremely important, I think, value, a moral value in our country. So it's great to be with you today, and I look forward to answering your questions.
Yeah.
Thank you.
Well, if you'll give me a chance to ask the first few questions. Sure. Could you tell us a little bit more about how your ideas about data ownership, who should own data, have changed over the years?
Right. I went to medical school. I began my medical school career only 7 years after Medicare and Medicaid had passed into law. That tells you how long ago it was. And we saw a lot of things happen in the subsequent years. But really, on up until at least our electronic system was put in, healthcare records were primarily handwritten, mm-hmm. and they were written in the provider's code. So very few people, in fact, I would get health records transferred to me by patients. And I wouldn't tell them this, but in many cases, I would have to throw them away.
Couldn't read them, I know.
I could not read them. What's the good of keeping them if you can't read them? Now, the lab and x-ray and reports and all of that, which were typed or printed, that made a lot of sense, but mm-hmm. it was very problematic. And providers were very cryptic because they were not in any way evaluated on the basis of the quality of the documentation. That's all changed now. And in fact, if anything, with electronic health records and the way we reimburse physicians, they're actually encouraged to over-document, excessively document. In fact, we call it note bloat. And so one of our biggest challenges is a simple office visit could create 3 pages of single-space text, which then the person who may read it downstream has to wade through all of that excess information to find a nugget of real information. And that's driven primarily by the way we reimburse. We reimburse based on levels of service, and that has to be reflected in your documentation. And it's real easy to click a few boxes on a computer, and you've got a lot of that documentation, documenting basically normal findings. So it is a situation where providers no longer have absolute control of that information. I think the rule of thumb on this is not per se a law, but just conceptually, is that patients own the data. The information is theirs and should be controlled by them in general. But the housing of it, the chart rack in the old days and certainly computers today are owned and controlled by the provider. And so, as you know, in the old days, we would charge patients to provide them a copy of their records. And it was reasonable to do that to some degree because it cost money to reproduce them. It took time and all that. But nowadays, once we begin to generate our electronic health records in a way that we can send them, there should be no cost to any patient for that. And then going back to the single record, that information can always be added to that single record that resides on a server someplace. We call it the cloud. And the patient can control all access to that. For instance, if I have mental health records embedded, I could give a certain code or password that you can access my records except for the sensitive data that's in there. So I think you're going to see more and more that patients will control their information, and that's a good thing.
That's really great news.
Yeah.
That's a wonderful direction. That's been one of the biggest problems with electronic records. The claim that sensitive information can't be kept separate from other information, but I think it's also been a false statement, essentially by industry to the powers that be in the government, because if you really can't segregate any information, like how about erroneous information? If you can segment erroneous information, which you better be doing,
Sure.
then it shouldn't be a problem to segment sensitive data. And so, that's it's going to be very important to people to decide which of their information they can share with whom.
And it opens up the other question that you're going to hear a lot more about in terms of patients actually putting their comments and data into that record as well. We're trying to figure out how that would work, but I think it's a good thing. Sometimes patients read their charts as they should, and they find out that the doctor got the story wrong, and they just need to, because going forward you don't want to repeat mistakes. So we're going to hear a lot more about that sort of thing.
You sound very much in favor of the patient. I'm so excited.
Well, I am. I think that's what this is all about. And to extend on that, when it comes to physician burden, which is, I think, one of my main concerns, and I know it is Dr. Price, is the more we require of providers that distracts them from their duties for direct patient care, the more the patient is hurt. So I think as we help the physician be a better physician and focus more time on the patient, we get better results. Because, again, at the end of the day, hopefully this is about the quality of patient care.
Yes, thank you. Let me ask a few other things about this. What are your thoughts about de-identified data? Patients are told, don't worry, It's de-identified. It's anonymized. Do you think that they should be concerned when they hear those words, or should they be should they relax?
I think there should be a healthy concern or skepticism about that, because de-identified data can be re-identified in some cases. I'm from a town of 13,000 people, and if somebody tells me, without telling me their name, that they treated a double amputee who's a librarian, I think I could figure that one out pretty fast.
Yeah.
I don't have to know the name or the sex or the Social Security number to be able to figure that out. So when there's been some testing done, we found that, it is quite possible to re-identify data. There is going to be a huge push in the future as we move towards pay for value, rather than fee for service, which is most of what we do today, that we collect data and hopefully collect it in real time, but we have to figure out a way to de-identify it so that not only is it safe and secure, but it is usable data. And I know CDC is going to be interested in this, NIH is going to be interested in this, FDA is going to be interested in this. The proprietary healthcare concerns, they're going to love to beg for data that can be provided right from our electronic health records. So we've got to be ready to deal with that. But on the other hand, just simply saying, well, we're not going to give the things that would typically identify a patient is a little bit naive. So we've got to be very careful about who we send that data to, how well it's de-identified, and what are the repercussions and the complications that may arise if somehow that's breached. And that's before you even get to the hacking issues and the ransomware and all that.
Thank you. Yeah. If your vision of patients being able to collect all of their own data and control that, have a single longitudinal copy of all their own data, that would be, of course, a tremendous thing. How would you connect that with, for example, the right to privacy? Are you suggesting some changes in policy that would support patient control over their information? It sounds like you are talking in that direction.
Well, I think that unfortunately we're going to have to beef up the protections of patient privacy, because the vulnerabilities become endless. So again, privacy is more a matter of policy. Now, sometimes laws and regulations have to go with that.
Sure.
But of course, everything seems to work around HIPAA. HIPAA is our sort of gold standard for sharing patient information. And HIPAA can be difficult and complicated to work with. For instance, a practicing physician perhaps sees a child and one of the parents calls and asks for information, but you happen to know that they're divorced. And so who has a right to that information? And these get to be complicated problems. Oftentimes, healthcare providers deal with it intuitively rather than going to each and every rule and regulation on these kind of things. Because you may not have the documentation that says that this child is under the total control of one parent versus another. But these are the kind of things that we get into, and I think that we're going to have to evolve our HIPAA standards and requirements to catch up with, or not necessarily catch up with, but keep up with the demands on privacy going forward with electronic health records. And again, Devin McGraw is here with us today. She's a lawyer and expert in the privacy area. She really wears two hats. She's in the OCR, the Office of Civil Rights, as well as wearing the hat in our office. And she's, as I say, she's our privacy law go-to person, our HIPAA person, if you will. And I know that she's constantly in the dynamics of what's happening day to day with that.
Oh, I think it was a great idea to keep her on this administration.
Yeah, exactly.
There should be at least some institutional memory, and she has more than memory. She knows where everything happened and how it happened.
Right. And it's not a political or partisan issue to begin with.
It shouldn't. No, it's not to the public.
No.
That's for sure.
Of course not.
It's not for the public. Yeah. Well, let me ask you about this. Since you're wading into HIPAA now on the side of the administration, right. What are the most confusing parts of HIPAA for you, and what do you want the health professionals, the providers, the doctors,
right.
to hear? I mean, and I'm. I know one of the things you've heard is absolutely from the doctors, which is, the ridiculous amount of time, and a system that takes the most highly trained people and turns them into data entry clerks.
Sure.
Seems like that's a mistake.
Absolutely.
So that's wonderful. But so what besides that? I think that will resonate with all the providers. What else?
Well, the HIPAA thing is, the default position on HIPAA is to give no information. In other words, you're safe as long as you don't acknowledge the patient or the patient's existence or give anything, then you're safe. But obviously that's impractical in a system where you have all of these different functions interacting with one another. I remember that a year or two after HIPAA came out, I called a family member who was in a mental hospital setting, just a private, really just a small hospital. It wasn't an institution or anything like that. And I would ask to speak to this person, and I would say their name, and they said, we can't acknowledge that person is here. Well, I go, well, how in the world am I going to be able to talk to this person? Because they did send me a note and ask me to call them. Mm-hmm. And then when I went to the next question, they would hang up on me. And I know what was happening. They were just in fear of what would happen in violating a HIPAA thing. And eventually I found out I had to have a code number. So I had to have a secret code to give them in order to have access to contact the patient. Now that's since been fixed. They don't do that anymore. But the point being that there's a lot of confusion, I think, and people just, in an abundance of caution, will do things that are far more restrictive than what is really intended in the law. The other thing is, I think HIPAA is often used really as a device to say no to things that you want to say no to. In other words, well, according to HIPAA, I can't do that, or I can't tell you, or whatever, when in fact it has nothing to do with HIPAA. Mm-hmm. So we have to be careful about that as well. So I think educating the public, making sure that our rules and regulations and standards are easy to understand and hopefully somewhat intuitive. I think it's good, but it's still a problem, but we've got to have it. We've got to have some standards out there, and there has to be some penalty for certainly a blatant abuse of that.
Well, that would clearly be helpful. Yes, everyone has noticed that somehow the information that people want for themselves and their family members, we can't get it, and right. Yet the data flows everywhere that we don't know, but yes. It hasn't been designed for the patients and right. the families. And right. It's wonderful to hear you say that that needs to change. Yes. Definitely. That needs to change. Thank you.
If I could just interject
a
personal experience. When I left Congress in January, I was an annuitant for about 3 months before I came to HHS. So I had some free time on my hands, and I decided to take my own advice. I went to see a couple of doctors, and I ended up with 3 patient portals in 3 different places, none of which communicate with each other. And in one office visit, I went in to see the doctor. Again, it was just a checkup. I didn't have really a complaint. Mm-hmm. And they said, well, before you can make the appointment, you've got to go into the patient portal. So I spent 20 minutes filling that out. Background, surgery, all of that kind of stuff. So then when I get to the doctor's office, they give me 6 sheets of paper asking the same questions. And in each one of them, I had to fill out the top with the same information, name, social security number, all of that. And then when they ushered me into the doctor's office, the doctor comes in. The doctor asked me many of the same questions. So you see the problem here. We have a lot of redundancy in our system. The system has not accommodated itself around the benefit of having an electronic record. Once the information is in there, we need to be sure it's accurate, and then that should be the go-to place when it comes to finding that information. And the other thing I would add that's, I think, very interesting to me is one of the topics that we talk a lot about, or beginning to, is telemedicine. Now, the first example I saw of telemedicine was back in the 80s when there was a grant to our hospital that they put in the newborn nursery, the NICU, a sort of a closed circuit TV screen and camera and all that, and they went through a lot of stuff, and they would connect it to the big hospital 30 miles away, and this was going to be a big deal and all of that. It never worked. It never worked. We never used it. It was a waste of money. So did we give up on telemedicine?
No.
Heck no. We've got telemedicine right here today, the iPhone. About 3 months ago, my daughter sent me a video of her daughter, my granddaughter, and she was having a croup attack. And this was at night. And she says, "Dad, what is this?" And I said, "It's just a simple croup attack." She says, "What do I do?" I said, "Well, just hook her up to your brother's breathing machine. He has cystic fibrosis. And it'll probably break the attack." And indeed it did. What did it do? It saved her probably a couple of $1,000s.
Absolutely.
Of going to the emergency room, probably taking the next day off from work, and all of the things that go with that. We should be using this, not of course exclusively, but we need to add to what we're doing as practitioners in treating patients, because we have all of these wonderful tools. What about if you're in the office with your doctor and you have a complaint that he or she feels, or perhaps you feel, needs a second opinion or a specialist opinion? Why not bring that specialist right into the exam room through your screen? You got the data right there that you can show the specialist. The specialist can talk to you. You can develop a relationship and then do a follow-up visit later after the appropriate tests have been ordered. I mean, think about the cost savings and the convenience and the ability to get more done in a shorter period of time. These are all things that technologically are really possible today. Why don't we do them? Because our reimbursement system is still old-timey. The reimbursement system is fee-for-service. We're paid as providers to provide service. And how do you bill for something like that? How do you bill for treating a patient with your iPhone? Currently, you can't do that, really. The way we can do that, though, is through alternative payment models, where you're paid not for providing service, but for being responsible for care. And then whatever you want to do under that helps you and your patients, it doesn't matter whether it's reimbursed or not. You're being paid for being responsible and providing care to that patient. So the way we reimburse is critical in the future of making these technologies work.
No, this is really fascinating, because part of what you're thinking about is really, why aren't these tools, like you say, telemedicine right here? Why isn't this? Why isn't it in healthcare? And there are great tools. They haven't actually been applied to what works for doctors and patients. And so, and I'm not sure about the billing side of it, but typically part of treatment is making appropriate referrals and connecting them up with the right person.
Yeah,
and so
absolutely. And you know that there's this time lag. For instance, you've got to make an appointment. You've got to send a letter. That's going to take time. When the patient sees the doctor is going to request some lab or certain tests. There'll be a report coming. This process could take easily 60 days. That could be all compressed within 3 days with using technology. You could literally have, particularly in a larger system, an accountable care organization or something like that, have doctors on standby, specialists that, just like being in an emergency room, you're there for those consults coming in, and pop, all of a sudden you come up on the screen, and you build that relationship, and you start the ball rolling in the right direction, rather than bumbling around for several weeks trying to get it all put together. So these are things. But again, if I'm not currently practicing today, but if I were, and I were to treat a patient the way I did with my daughter, there's no mechanism to be reimbursed for that. And so oftentimes doctors are forced to be in a position that in order to meet their expenses and overhead, they've got to get the patient into their exam room, because that's the only legitimate way, really, to...
So you're talking about the reimbursement to the referral doctor?
Well, even to the treating physician. In other words, either way, the mechanism requires a patient to be present in front of you.
Yeah, yeah.
And that's something... Now, you might say, well, okay, let's charge for phone calls then. Well, that doesn't work, because what happens is you can think of the fraud, waste, and abuse that could occur from a system that, again, pays you to do things that can't be verified. So you see you've got integrity problems when it comes to CMS and all that. So that's why advanced payment is a way to go, because if you're paid like a capitated rate, and I've been through that with HMOs, it works very nicely. You're paid, say, $80 a month to be responsible for a patient's care, whether you see them or not, and then you're judged on quality, on how well you're taking care of the patient, and there's mechanisms to do that, rather than how many times you see them, what you do to them, and those kind of things. So this way, a provider can match the resources to the need, rather than, again, going through the formalities of office visits and things that may or may not be truly necessary.
Yeah, no, this is fascinating, and I think that the capitated models are very interesting, but they may not fit certain specialties.
True.
I would hate to take, I don't know, some capitated payment for some huge, number of patients, because they really need different amounts of time.
Yeah,
So, but anyway.
That's true. You really have to have an integrated model.
Yeah.
It primarily works to have primary care physicians on the capitated
Which we need
basis.
more of.
Right.
We need more of.
We do.
Well, let's shift a little bit. This year, we were talking primarily, we started the summit really with looking at global effects on our privacy rules and on the GDPR. And, optimistically, this is the 7th summit. We called this the International Summits on the Future of Privacy, of Health Privacy, very early. And we had one person from the UK the first year. But we know that these are global issues, and we've had some of the best global experts in the world here this year and others. But how do you think the United States can engage with other countries for research and data sharing, given the potentially much more restrictive new rules over there for research? And yeah, do you have some thoughts about how that can be worked out?
Look, there's no question that as soon as we become substantially interoperable, that healthcare will be a worldwide system. I mean, in terms of communication, in terms of information. I mean, think about it. People travel more and more today overseas. If you have a single unified health record in the cloud, it could be accessible from any place in the world. So how do you bring those, I think your question is, how do you bring those standards together in a way that works? We actually have that problem within the United States, because in terms of privacy laws and rules, they vary from one state to another.
Yes.
So it's already a kind of a landmine, a landfield.
The way to fix the different standards across the country is if we start with the best, the highest standards.
Right. Well, that may be true.
Kind of the California effect, you might say.
That's a good point. I mean, I'm not, HHS, and certainly I don't take any certain position on that.
Yeah, no,
the tendency that we have is to build a consensus, because, again, things work differently in different places. cultures, the way the healthcare system is. For instance, the National Health Service, that got hacked and so forth.
Yeah.
Their system is different than our system, and the vulnerabilities may be different. And so I'm hesitant to say, well, let's just go to whatever the strictest standard is. I could see some value in that, but on the other hand, because we're still different cultures, different economies, I do think we have to work together and build a consensus for those solutions.
No, of course you're right. Of course. So what's next for you with privacy and ONC?
Well, again, our top two priorities are usability and interoperability, because privacy doesn't matter a whole lot if you're not able to send the information to begin with.
Mm-hmm.
So we're working very closely both on policy and on standards, because as we begin to have machines talking to machines,
Mm-hmm.
we need to build in, of course, interoperability standards. But there also has to be safety, security standards as well, and then building trust, as you heard earlier.
Mm-hmm.
If you can't trust the system, you're not going to be honest in that system. I'm not going to tell somebody something about me that might be scary or could prevent me from getting a job someday,
Mm-hmm.
or could be embarrassing if I think the system does not have security and integrity. So all of those do come together in a triad, and so we're walking parallel with safety, security, privacy, along with the interoperability piece that we're doing.
Well, I'm sure you've thought of this, but there are many of the institutions that hold patient data that actually don't want it to flow to other
Right.
institutions
Yes.
for business reasons.
Right.
And, one of the solutions could be if patients get their longitudinal record where they are able to aggregate everything together, would be to allow them to send their data to,
Mm-hmm.
for a second opinion, or to a different
Right.
hospital if they're to different systems. I
Right.
mean, the patients could overcome some of the
Sure.
barriers if they said, well,
Right.
I want to be seen at these 2 different places
Right.
or 3 different places that are part of different systems. We're having that exact thing happen in Austin. We have high competition between major hospital chains. There's at least 2 majors and several minors, because
Right.
Austin's a growing city, and so
Sure.
you can end up in 3 different places that are literally within a few miles of each other, and
Right.
the data cannot be exchanged. They will not exchange it.
Right.
And so
Well, this
could
could-
patients be a solution to it?
Well, it could be. The issue there is what we call information blocking,
Mm-hmm.
and it's a complex issue. It's not exactly what it sounds like. It sounds like what you described, which does happen. There's no question about it. But that is not the only part of it that has to be considered.
Okay.
Information blocking might be for proprietary reasons. It can be because you want to capture the patient. You just don't want the patient to go elsewhere.
Sure.
But more importantly, it's about intellectual property, because you have to build an app to connect the systems together. And that means that you have to give proprietary information to other competitors who may find that gives them a competitive advantage over you.
How is our health data somebody's proprietary
It's not the
information?
data itself, it's the software interconnect. It's that piece. It's not the data.
Okay.
For instance, let's say I'm United Health and you're Athena,
Uh-huh.
and somebody wants us to connect our systems.
Mm-hmm.
Well, your programmers have designed that system in a certain way that you think is optimum, and you think it's twice as good as our system. Well, in order for us to talk with you, what we have to do is we've got to know more about how your system works on a very technical and down in the roots level.
Mm-hmm.
And so if you seem to have an advantage, technologically speaking,
Mm-hmm.
I'd want to connect with you because I'd want to know how your system works, because I might want to use it for my system. Or I might want to use it in a way to make you more vulnerable. So these are the kind of battles that go on. As a rule, healthcare systems, clinics, hospitals are not so reluctant to deliver the patient data. It's the
Okay.
interconnectivity that is the problem. And that's the reason why oftentimes, technologically speaking, we might be able to send data from one hospital to another or one clinic to another. But it's the intellectual property piece of that we've got to somehow find a way to get around that. And that's why we have organizations out there who are working with all of them, or the major vendors out there, such as eClinicalWorks and, I forget some of the big ones out there, but to come up with some standards on how we interconnect with each other. And so it's more about intellectual property when it comes to interconnectivity than it is the actual patient information.
Well, I'm not a lawyer, so I can't go any further with that.
And I'd be happy to,
but this is great, yeah.
If anybody, Devin, would you like
take some questions?
comment on that piece of it? I mean, it's a very complex issue, information blocking.
Yeah. Well, I mean, only to say that it's something that.
Do you want to come up here so people can, the audience can hear her? Yeah.
Under the 21st Century Cures Act, there is a requirement for ONC and the Office of the Inspector General to work together to define what constitutes information blocking, and then there's penalty authority that the Inspector General then has to penalize what constitutes information blocking. But all that is, there's a process whereby that has to be developed. And so certainly there are technology experts, there are policy experts that are right now working together to develop those standards. So, I don't want to comment on the technical aspects because that's absolutely beyond my capacity to do. But in terms of, the issue of information blocking and what's being done about it from a policy standpoint, again, 21st Century Cures enacted in December, charges HHS, ONC and OIG in particular with developing some accountability around this issue and defining again what it means and what the penalties would attach to and how that process would take place.
Yeah.
So if that's helpful.
Yeah, it's not necessarily malicious.
Yeah.
It can be for many different reasons. Sometimes the problem is, for instance, if you may be sold a system and told that it's going to interconnect with other systems, and then you go, well, it's not doing that. And you go, oh, well, we forgot to tell you it'll be $50,000 for us to build an API to do that.
Exactly.
So there are many different issues. It's not just a malicious or deliberate thing. Sometimes it can be for many different factors. With 21st Century Cures, we do have the requirement to enforce that. The problem is defining information blocking because sometimes, again, it's a technical issue and it just has to be solved. It's not deliberate, it's not intended, it's just the way it is.
Well, I think you've raised so many wonderful new areas that we all would, we're very glad to hear about your interest, particularly in strengthening the doctor-patient relationship and patients' rights and the questions about solutions. I know this audience wants to engage very much, but we're a little behind, and so I think we have to stop for now. But we will be glad to. We can. Why don't you send us the questions, and we'll be happy to send them.
Just a comment. I just want to say that technology is not the problem.
Well, yes, and I think the technologists here would love to offer some alternative views about the possibilities of technology and the problems with
Well, see, I'm
proprietary systems. So
I'm going to pull Congressman here.
Yeah.
Hey, I don't know much about technology, okay? I'm just telling you what the experts tell me.
I hear you. No, thank you. And there are lots of technology experts here, so I'm sure they can send some comments, and we'll make sure that they get to you. So thank you.
Yeah,
thank you very much for coming.
Yes, and very much.
Really,
absolutely.
what a pleasure. Yes. Your heart is absolutely